Hi everybody, I'm Dr. Rosie Roeder, board certified plastic surgeon with my co-host
Andrea Spar, board certified dermatology PA.
And we are the Rejuveness podcast. Today we're going to be talking about breast augmentation.
It's all about the implants.
It's all about the implants. And we got some with us today as well because we just want to talk about what women really want to know even before they come to the clinic for a consult.
Now, most people typically don't know much about implants when they come in for a consult, so that's why they're making multiple consults from multiple providers to see what's out there to offer.
That's right. Nowadays, there's a lot more people getting information online before they even come to a doctor, and they're going to multiple different surgeons. They're interviewing their surgeon. It's almost like you're in an audition process, right? Sometimes beforehand, they check you out on Instagram. They look at your before and afters. So we want to just give a little bit of an introduction as to the most common questions that I get, and in a way that it is very evidence-based and gives women like the skinny on it without it being super hyped up, and to eliminate a lot of the conflict of interest. Really, this is genuinely the rhetoric I give every day in a consult, just to give patients the best information that's out there.
And I've done many years of consults with my previous doctor, so I've listened to them all. I'm here to give you the deets as well.
Yes, because remember that Andrea was a medical assistant and a scrub tech, so she's been on the consult side with a surgeon, as well as being the one to hand us instruments. And you guys are very critical as scrub techs, right? And like looking at the patient and making sure that the outcomes that the patient wants is what we're delivering, because you've seen that patient through the whole entire consult process and in the operating room. And sometimes my techs are the best at being like, oh, remember, like she said, the biggest one you can get in there, or, you know, she wants to have a lower profile. And I mean, I like to use sizers to see what things are going to look like.
Right.
So there's more than just one eye in the operating room. I guess that's what I'm getting at, right?
Definitely.
And you have been that second pair of eyes to make sure that we're honoring the patient's wants and needs.
So I think most patients want to know about basically where we would start. So we want to talk about what type of implants there are out there?
Yeah, sure. And I brought a few with me, a couple of different companies. We have consignment for mental implants in our practice. It's a company where the implants are made in Texas. I am very familiar with using them for a wide variety of reasons, but I think they have a huge portfolio. So I brought just different types that we use. So implants can be made out of silicone, and they have a different feel to them. They can also be filled with saline. Important thing to note is that the shell is made of silicone. So even if the fill of the implant is saline, your body will still see silicone because it's going to see the outer shell. And there are smooth implants, which is what you saw on the first two right here, and textured implants. And some of the textured implants have been removed from the market because of a type of cancer seen associated with the implant capsule, which is a scar tissue that naturally forms around an implant. And now we're only left in the market with micro-textured implants that very rarely lead to that problem. But we will talk about that a little bit later in the podcast about risks of the operation. And these are Motiva implants. They're the latest ones that have been FDA approved in the market. So there's a lot of curiosity about them. So I thought I would bring them because we want to talk about the cutting edge. We want to talk about the new things that are available in the market that people may not have seen.
And they are very pretty compared to the
pretty.
other ones.
Yes, they're very pretty. They're considered smooth implants, even though they're nano textured. So that can incur some advantages as well. Very, they're less inflammatory, let's put it that way. They don't cause a thicker capsule. They're very thin capsules. So that really helps with patients that have had, let's say, a history of capsular contractures, which is thickening of that scar tissue that builds around the implant. So they're definitely supposed to be better with that. They have two different types. One of them is called the ergonomic, so it's supposed to move with the patient. So if you go to their website and you look at the way that it moves with the patient, it's supposed to be a more natural look. So it's for those patients that want maybe a more natural, let's say, changes in positions. They can see the change in position. It's not just a like sort of a stiffer implant that will maintain its roundness. Although there's some women that really just want that rounded look.
And I was about to say, is there an actual like right fit for the specific patients? Because some people are very tiny. They weigh 100 pounds and they may say, I've been looking at somebody that's got 600cc implants.
Right.
Is that legitly going to fit in there?
It's going to be really tight, and sometimes it's not going to. And you have to be really realistic about listening to what the patient wants and then being able to deliver that.
Right.
So I tell them that we have to respect their anatomy. That is the most important thing, right? You are bounded by what God has given you. And our job is to try to enhance that with the tools that we get. So one of the most important things is your breast base width. So as you come in for a consult, we're going to do a breast examination. We are going to be feeling for your breast texture, the quality of your skin. We're going to be looking for lumps and bumps. That's a very important part of the screening. And then we're going to be taking some measurements. The traditional measurements are to measure from the sternal notch, which is right up here, to the nipple distance. That lets us know where your nipple position is, if everything is even, or if there's asymmetries, which are normal. They're all cousins. Yep. They're not even sisters, right? So there's going to be some asymmetries. We just want to know that ahead of time. So if there's something that we need to correct, or the patient wants to correct, we know exactly how to do that on a very systematic basis. Then we look at the measurement from the nipple to the inframammary fold. That also gives us some information. We put that on stretch, and that tells us how much volume we can accommodate, and then we'll look at your breast width. So to me, those are the most critical measurements. There are others out there that we use, but those are the critical ones to really make sure that we're picking the best implant to fit your anatomy that's going to give you that result.
And narrowing down that size range that they can actually feel comfortable in their own clothes.
Correct. Okay. And there are different types of implants, different heights of implants, right? We call it projection. So there's some that are moderate or low projection, and then there's ultra high, which is super high projecting, and everything in between. And all the implant companies, Mentor, Allergan, Sientra, Motiva, they all have a variety of implants that will fit a particular base width. So once you're within that base width, that projection might change depending on the volume that you want. So if you're very narrow and you want a lot of volume, you're going to be more projecting, right? So it's not going to be for that person that wants a subtle enhancement. So that's what's important to know. How many cup sizes do you want to go up by? What is good for your anatomy? And then we'll pick the profile that's more in tune with your wants and the aesthetics that you're looking for.
Now, do y'all use that Vectra machine in y'all's office like we used to, and to show people kind of what the sizes would look like on them so they can get more of a visual?
Yeah, I still do.
Love Vectra.
I love it too. I think that there are many tools we can give patients, and if we have it, then we should provide them with the best estimate of what they're going to look like afterwards. Yeah. Is it perfect?
Nothing ever is.
No. There are some people that for their anatomy or for whatever reason, it just doesn't look exactly like you know it's going to look in the end, but it gives you a measure of what you can potentially achieve.
And the good thing is, I think what we used to do is we would give them a side-by-side view of like their max and what their lower one was, and they could see what the major difference was. Because a lot of people think 50 cc's is a lot, but in reality, how much is it actually?
Well, like a shot glass, right? I mean, it's not that much, 25, 50 cc's, it's not. But it's going to make a difference whether or not you already started off with an A cup or a C cup, right? That 50 cc is going to make a bigger difference on somebody who has smaller breasts and somebody who already has some volume, and we're, let's say, just filling a space that was left after postpartum breastfeeding, right, where they had skin deflation. So that's going to be very different than somebody coming to you at 22 years of age with a breast that have never experienced pregnancies or any other hormonal changes, right? So I think that that's where the finessing what a cup size really means to someone is important, and why you need to have an experienced plastic surgeon who has done multiple breast operations to gauge, based on your chest size, based on your height. Because I'll tell you that even like petite women like us, like 50 cc's makes a bigger difference than somebody who's 6 feet tall.
Right. And then you were talking about age.
Yeah.
What's the oldest person you've put implants in on?
Well, that depends on whether or not it was for cosmetic reasons or for reconstruction.
Let's talk cosmetic first.
But cosmetic, I just did a primary, meaning first time, breast augmentation on a 69-year-old.
See, so implants can be done pretty much anytime.
Yep. I mean, she is very healthy, very spunky, and she finally got to the place in her life where she could afford it, and she was in the right situation to get them done. And she was so excited. She had just the perfect anatomy, too, for somebody who wanted to get a breast augmentation, and she's done extremely well. So as long as you're healthy and you have the right proportions for a straightforward breast augmentation, then I mean, I think we'll go ahead. Yeah. We try to make sure we make it as safe as possible for all of our patients. Of course, they go through a preoperative screening, right, for that purpose. But it was great. And when it comes to reconstruction, so for patients that have had breast cancer, I've switched out implants on women in their late 70s, early 80s.
Mm-hmm. Now, gel in general is 18 and older?
So, yes. So there's saline implants and silicone implants have different FDA approval rates. And that's not because there's anything wrong with using a silicone implant at a younger age, but just that the studies didn't include them. So per the FDA, women have to be 22 years of age or older in order to have a silicone implant, and 18 years of older to have a saline implant for cosmetic reasons. Now, if this is a reconstruction problem, either they had breast cancer really early or some other let's just say anatomical variants that you can see that are developmental problems of the breast. And there's a few different reasons for that where the breast didn't develop, then they can have a silicone implant. But when it comes to cosmetic, 18 plus for augs in general, at least in my practice, and 22 and older for silicone implants.
Gotcha. Now, and I think a lot of people come in and they always say, I read online, it says I have to change these out every 10 years.
Yes, that's very common. So the reason for that is because that perception comes associated with the warranty that we're given in implants. So implants have been around for 80 years almost now, 70 years they've been around, and there's been an evolution in implants. At first, they were very liquid, silicone gel within these shells.
Almost like a molasses.
They were very porous, and they would move, and there could be some leakage. With time, the shells got better. Now there's double shells in here that prevent silicone leakage. The cohesiveness of the gel is greater, so you can have cohesive gels or highly cohesive gels. So when you slice through an implant, I think I have a video on my Instagram somewhere about that, but you don't see liquid gel flowing out. They look more like gummy bears.
It's literally like a gummy bear. You squeeze and it goes right back in.
Right. So it's very different. So there's been an evolution over time. With the technology of the shells have also improved with that. So now a lot of the implant companies give much greater warranties. Tell everybody that this is a man-made device, right? It's not meant to last forever. So like anything in your house, at some point it's going to give, right? So it's not meant to be a lifelong device. But that doesn't mean that there's a stamp or a period in time in which that's going to happen.
Right. So
if you think about how long the company is insuring that implant for, I'm going to guarantee you that more than 95% of people are going to be okay within that frame of time in terms of rupture, right? Because they don't want to be paying for you to get these replaced for no reason. So you don't have to change it at 10 years. You don't have to change it at 20 years. If they're doing well, if they're in good position, you're happy with them, they feel good, then you don't have to change it. Now, we do have screening for silicone implants that's indicated by the FDA as well. So that screening now starts after you've had the implants in place for 5 to 6 years, and they should be done every 2 to 3 years. This can be done with an ultrasound or with an MRI. So a lot of plastic surgeons now have the technology to do in-office ultrasound. I offer that myself.
Right.
I was not an earlier adopter like some of the other trailblazing plastic surgeons that I know, but I'm trying to learn from them and gather more data. And I'm screening every implant that comes through my door just so that I can gain the experience to do it. And the software is so amazing, and AI technology is coming into play that you can pretty much scan and you're going to be able to just look at your phone screen or your iPad and know that that implant is ruptured with all the new technology that's coming. So experienced ultrasonographers, because the ultrasound's only as good as the person screening and reading it.
Correct.
Is fantastic. Sometimes when I am not 100% certain, then you correlate that with an MRI. The MRI is probably still the gold standard, but definitely a more expensive technology. Like, I don't charge my own patients to ultrasound their implants. I don't know what other people do, but an MRI is always going to get a charge, and sometimes insurance will cover it and sometimes insurance will not.
And like mine didn't cover it. I just paid out of pocket for my breast MRI last year.
Right. And you can actually negotiate good prices with an imaging center to do that. So it's important to know that you have options to do that. So if it's equivocal or we're not sure, we follow it up with an MRI. It's a lot more sensitive to tell you if there's a rupture. And what we're looking for is silent ruptures. So everything feels fine. Everything is in good place, but something's happening, a little crack in the gel internally, which means that you might have a problem in the future that we're trying to prevent. So that's the point in doing these screenings. Now, for saline, though, I mean, if it ruptures, the water's going to leak out. You're going to know right away. You're going to wake up one morning, you're going to be like, oh, it's gone. You know, so then
the
you know
balloon
it's time.
has popped.
The balloon has popped.
Yeah.
So you know it's time to exchange it. So that's really kind of the difference between the two types. There's advantages and disadvantages to everything in life, right? Nothing is 100% fail-proof or perfect for anybody. And I have patients that request saline implants because they rather not have to have screening. They rather know that if a rupture happens, that they're deflated and they'll have to change it. And I have some patients that are like, oh, I love the feel of silicone. I know it feels more natural to me and that's what I want. And I'm willing to undergo the screenings that are necessary. It's all about getting appropriate informed consent from your surgeon.
Yeah.
You can never leave that consultation room not having asked all the questions that you want to ask without having an understanding of the process that you're going through.
Now, you were saying, you know, we talked about longevity and having to price out that. Why would be another reason for patients to come in to have revisions done with the implants?
So there are a couple of common reasons. We see most commonly within the first year, it's sizing. A lot of it is that they wish they were bigger, and it's because they're adapted to the new normal, right? So they were looking for upsize, 2 or 3 cup sizes. Inevitably, I think 95% of people that come through my office, whether they're wanting an augmentation or a breast reduction, right? They want to be like a full C, whatever that means to them.
Right.
Right? I think we can all kind of picture in our bodies or in other women what we'll perceive a full C to be. But then they get that full C and they're like, well, I mean, now I wish I had gone bigger, right? Because they just got so used to their new normal. So I think as surgeons, what we want to do is really get patients as close as possible to what they're going to be happy with indefinitely. Now, the other reasons that people need revisions is malposition. That scar tissue that forms around the implant is a natural body reaction. Just like if you got shot with a BB gun. Your body's going to want to isolate that BB, putting a capsule around it. It's just a little thin scar tissue. It feels like thin as tissue paper. Now, some people form really, really thin capsules and their pockets stretch over time. Either due to skin quality or weight loss is a very common thing these days. And then the implants shift. So it can shift laterally is the most common thing that I see, because when you're lying down, the implants want to follow the curvature of the chest and migrate laterally. So it's an easy fix to fix that, but it does mean you got to return to the operating room. Superior malposition, meaning the implant stays high, riding high, is another reason. Usually there's a little band of tissue or muscle that wasn't released.
Holding it up on your clavicle.
Yeah. So after you get an augmentation,
it's going to be high anyways.
Your implants are going to be high.
Yes.
Yeah. You're going to look like a linebacker until it kind of settles. It might take a month or 3 months to settle, but after that, they should be in the position that they're going to. So if you have a superior malposition, we have to go in there, release that band of tissue to let it drop. So those, I think, are the most common. Sometimes over time, the implants will migrate below your inframammary fold, which is a inferior malposition, and that means you have to re-tack up that inframammary fold. So that's another reason for revision. And those are really the most common ones. Then long term, if that scar tissue becomes hardened with time. We call it a capsular contracture, which the rates these days are like 5% or less, really, if you have good technique and the newer generation.
As I say, especially with the new implants, because they have good data on that.
Very good data. Like, I think the Motiva implants have a 1.4% or less, if I remember correctly, from their data. The other companies are not far behind that either. Like, I follow a protocol that's been very well studied to help prevent capsular contracture. That is my main goal in my operation, is making incisions in the place where it leads to the least amount of complications, placing the implant in the location that leads to the least amount of long-term complications. There are small things like covering the nipples during surgery. We change gloves as we're putting the new implants in, wash out the pocket with antibiotic solution. I mean, I've been in practice for 8 years. I've had no infection. I mean, 0 on a primary augmentation. So that's a really great thing. Bleeding after surgery is very, very uncommon. And one thing I get asked about all the time too is recovery. And I mean, you've seen tons of patients go through
It's different for everybody too.
Stages of recovery.
Some people are like, I just took Tylenol and went on with it. When I had mine done, I just felt like I did a bunch of push-ups. So, but I've seen people that are crippled for 2 weeks because they're like, I can't move my arm. So it's different for everybody.
Yeah. So one of the things that I do is I use local anesthetic in my pockets. I use it on the muscle fascia. I use it on my incisions. I tell patients ahead of time what to expect, and they're going to have a lot of tightness on their chest. The bigger the implant that you put in, more tightness you're going to feel, obviously, because of the expansion. And I use a lot of muscle relaxants and ibuprofen combination. And I think all my patients have a rapid recovery. Sort of this buzzword that some people go to seek a surgeons because they put on their website that they do a rapid recovery. I said, I don't even know any other way to do this. Like, who wants a long recovery for their patients? Like, you know, it's great marketing, and I guess maybe I should put it on our website that I do a rapid recovery, but I think all my patients have
the majority of them typically do.
I usually operate on Thursdays, and I'll tell them to really take it easy that weekend, but if they're my first patient of the day, if they want to go out to dinner that night, they can, and the majority of them feel okay to do so. Like, I'm not a huge proponent of that, but just, you know, I think you should chill for a day. But they mostly come to my office the next day and they're doing great. They tend to do normal things over the weekend. I tell them to just stay away from anything that's very physical. And by the next Monday or Tuesday, as long as they're off narcotic pain medicines, which I think 99% of my patients are, in 3 days, and they feel comfortable, then I think it's safe for them to get back and forth to work as long as they have a desk job. I'm like, if you're an UPS like driver and you have to carry a lot of big packages, right?
Might be a little tender.
Right. Or in my area where there's a lot of sewers and people that work in industry, in the furniture world, maybe you have to take a little bit longer just because of the strain on your pec muscles. But most average people are back to work within 3 to 5 days and driving. After 2 weeks, let's start increasing the amount of activities. And at 4 weeks, they're back to doing everything and anything without any restrictions. And I've really had no issues with that whatsoever.
Now, in closing, because people can come see you for a consult at this point. What were 3 things you would give as a takeaway from teaching about breast implants today? That
breast implants are really one of the most studied medical devices out there. I mean, just Mentor alone has done 10 long-term studies on implants. Motiva is going into the market. They've been outside the United States for 15 years now, and every company has done tons and tons of studies, especially to get implants back into the market after the moratorium. So they're really well studied. They're safe devices. That doesn't mean that somebody may not have a bad experience with them. And we do acknowledge that for some people, breast implants are not for them. And if they did have any adverse reactions to them, or they feel like they're just not for them, either they're in not the look that they wanted, or they don't feel well after implants, having them removed is okay too. You know, there's many different ways to skin a cat, and plastic surgeons are really good at trying to deliver you a good outcome with different types of technology. So this is not the only way to augment a breast. But I wanted to say that I think we take our responsibility seriously and bring this technology to patients and making it so it's the safe and the best experience that they have to get something that they want to achieve for themselves. It's not about vanity, it's about confidence. It's about you showing your your best self to the world and making yourself feel good and empowered with your body and who you are. So I think that's the second takeaway. Don't judge. It's about what the patient wants and what makes them feel feminine and what makes them feel confident about themselves. And I think the third one is that make sure you find somebody who really listens to what you want and can deliver to you and is honest with you about your outcomes. Respect your recovery. Don't try to be too quick in recovering, but do know that, and I don't want to trivialize that by any means, but that it's an operation where we can get you back to your normal life in a reasonable amount of time, very safely. And I think for most women, it's sort of life-changing for them in a positive way.
That was amazing. Thank you for talking to us about that today. Now, if anybody has any comments, questions, leave them below. We can always come back and answer them in later podcasts. You can always get a consult with Dr. Rosie Roeder over here at our Hickory office. We have plenty of plastic surgeons in all locations, though.
Yeah, and that might be another takeaway, too, that this is a surgery that is sort of bread and butter for a lot of plastic surgeons, right? A lot of people in our practice, in our surrounding area, they do this operation very commonly. It was one of the top operations in the United States. So do your research, be safe, but don't feel like you have to travel long distances to have a procedure that is in the armamentarium of every plastic surgeon, really.
Alrighty.
All right. Well, I'm Dr. Rosie Roeder.
And I'm Andrea Spar.
And we are the Rejuvenez Podcast. We'll catch you next time.